Yeah. Good evening, everyone. Yeah, it gives me immense pleasure to welcome you all to our most awaited ISCCM monthly webinar. Today, this month's topic is abdominal emergencies in ICU, which has a significant impact on the patient outcome. To enlighten us, we are having an esteemed faculty, Dr. Lalit uh, Gauri ma'am, as a moderator, and our mentor is Dr. Deepak Govil sir. Ma'am, Lalit ma'am, may I request you to kindly give an opening remarks. It's over to you, ma'am.
Okay, so welcome to all on behalf of ISCCM to today's webinar, where we will be discussing two issues related to the abdomen or the gastrointestinal tract, and then we have a panel discussion on ALF. Our mentor for today is Dr. Deepak Govil. Sir is the past president of Indian Society of Critical Care Medicine, and he is the vice chairman of critical care at Medanta, the Medicity, Gurgaon. Welcome, sir. I hand over the mic to Govil sir to please give a brief comment before we start our first talk.
Yeah, good evening, dear friends. On the behalf of Indian Society of Critical Care Medicine, I welcome you all to this exciting session. As we have already discussed, we are having the session today on two things, mainly the three things, especially the pancreatitis, the mesenteric ischemia, and acute liver failure. So without wasting much time, I request the Dr. Gauri to start.
Okay, so I'm Dr. Lalita Gauri Mitra. I look after the Department for Anesthesia Critical Care at Homi Bhabha Cancer Center at New Chandigarh. We are a unit of TMH Mumbai. I thank Dr. Professor Bhattacharya and Dr. Samavedan for giving me this opportunity to moderate this session. And with your permission, sir, I first invite our first speaker. He is Dr. Vishwas Mohanty. He heads the Department of Critical Care at Utkal Hospital, Bhubaneswar. As we are all aware that acute pancreatitis is an inflammatory condition and of the pancreas, which is usually caused by bile stones or excessive use of alcohol. But most of these patients will have some kind of a mild disease, but almost 20 to 30% of our patients do develop a severe form, and then they have one or maybe multi-organ dysfunction, which requires an intensive care management. And one of the major challenges in managing these patients is to identify these severe forms quite early. So I invite Dr. Vishwas Mohanty to take the dais. And I'll stop my presentation here and he will take over from here.
Yeah, very good evening to all of you. Thanks ISCCM for giving me the opportunity. My respected seniors, my mentor, all the chairperson and all the senior faculties. And without wasting time, I will start my presentation. This is the challenge in the management of the acute pancreatitis in the intensive care unit. I think I am audible. Yeah. So,
yes, doctor.
Yeah. So why they have choose this topic? Because in 2019, India is the country with greatest number of incidence case of acute pancreatitis, with a global incidence almost 33.7 per 1 lakh, with a disease death almost 1.4 death per 1 lakh population. With this, I'll go with a case. This is a 34-year male alcoholic presented to our hospital with severe abdominal pain for 5 days. On examination, his conscious but is extremely tachypneic. Saturation, he was maintaining hardly 92% on room air. Extreme tachycardic. BP unsupported, it is 112 or 54. On the lab investigation, amylase lipase slightly above normal, or you can tell it's in the normal range. And TLC is in the higher range. Hemoglobin is 16.8 with PCB around 49. Creatinine is 1.87 and the liver enzymes almost normal. On the ultrasound, there is diffuse edema of the pancreas. There is no GB stone. X-ray, it is mild left pleural effusion. And the initial presentation ABG is showing respiratory alkalosis. So initially, he was managed with some IV fluid. For pain, started with the tramadol. Due to severe abdominal pain, kept NBM for 2 days. but the pain and abdomen worsened, urine outputs decreased. So the create's gone up to 2.2 on the day 3. As it is gone off and the abdomen pain is persisted, so we have gone for further imaging. As the create is high, so we have gone for MRI abdomen. It shows severe necrotizing pancreatitis. Due to persistent rise in TLC, ongoing fever, we have to empirical started antibiotics with the piperacin tazobactam after setting the culture. Due to worsening hypoxemia and gross abdominal distension, patient has to intubated. Then we have started some trophic feeding, but gradually day 9 onwards starts urine outputs increases, TLC and creatinine downtrend, SpO2 improved, and we are able to extubate the patient on day 12, and the patient is able to shift to the cabin on day 15. With this case, we'll go. There are a lot of guidelines. The recent one I have shown you, it is published in 2024. This is American College of Gastroenterology guideline. But there are a lot of challenges still persist. What I have shown you is starting from the diagnosis, severity assessment, imaging, food management, antibiotics, nutrition, like all the day-to-day care in the ICU, there is still in the challenges. I am not going in detail for the guideline. I'll just go through what are the challenges we usually face in the management of acute pancreatitis in the ICU. First, coming to the diagnosis. As already we know that for the diagnosis of the acute pancreatitis, there should be some abdominal pain which is consistent to disease, along with the amylase and lipase should be more than 3 times the upper limit of the normal, along with some abdominal imaging to confirm the diagnosis. But in some cases, we found lipase is also elevated in variety of non-pancreatic diseases. Also, enzymes may even normal in 1/5 of the patients on admission. Some patients without pancreatitis also elevated amylase lipase, even more than 3 times of the normal. In that cases, sometimes we confuse whether it is pancreatitis or not. Then we go for the imaging. In the imaging, there are 3 things. Important things is the ultrasound. Every patient presented to our hospital or intensive care unit would start with the ultrasound of the abdomen. But you see, in cases of the acute pancreatitis, almost 25 to 45% of severe acute pancreatitis, pancreatic region is not feasible. And it is limited ability to identify peripancreatic region or necrosis. In that cases, we tempted to go for a CT scan of the abdomen. But early CT, all the guidelines are not in favor of the early CT because it is of no therapeutic benefit and it's not benefit of the severity assessment. Apart from that, we know that any imaging of the abdomen, we have to go for a contrast, especially for the pancreas. But it has, if you go for a CT contrast, as in my cases, it has go for AKI. In that case, we go for MRI abdomen. Though MRI has a lot of advantage over CT, like contrast allergy and renal insufficiency will be less in cases of the MRI, and it can detect stone in the CBD and pancreatic duct disruption, but it has its own limitations, like it is expensive and not found in all centers. It is time consuming, and especially for claustrophobic patient, it's very challenging to go for a MRI. Now, in which case we go for an early ERCP. As you know that emergency ERCP, usually we go for when we suspect acute biliary pancreatitis with features of cholangitis. But the rest of the patients in biliary pancreatitis, the role of urgent ERCP is controversial. That's why early ERCP, especially we keep it for cholangitis with biliary pancreatitis. Now, come to when these patients come to us, we should go for a severity assessment. Accordingly, we decide in which area we should keep this patient. So the commonly used criteria like Apache score, Ranson score, which rely on the complex and poorly recalled criteria like hematocrit, imaging, BUN, creat, LDH, they have their own limitations. Apart from that, most of the criteria, they take death as an outcome. With the overall mortality declining over the last few decades in all over the world, I think it should be considered whether death should remain as the principal outcome. Apart from that, all the like Apache score, Ranson's criteria, it takes more than 24 hours to stratify this patient. By that time, actually, we have already loss of time in some critically ill patients. Apart from that, positive predictability value for the scores like Ranson score and the Apache score. If you see Ranson score, the positive predictive value, it's almost 28 to 50%. And Apache score is 55% after 48 hours. Still, we use this criteria in a lot of the ICU, but nowadays in all the guidelines, they are telling that if the patient is having persistent of the SARS, this is the most common and practically used prognosticator in all the intensive care unit. That means we should take SARS as if the SARS is persistent even after 3 days, then you can think that this patient is going to be in severe acute pancreatitis. Now, coming to the fluid treatment aspect, any patient coming to intensive care unit, the first and foremost therapy is the fluid therapy. But as you know that crystalloid is usually preferred over colloid in all types of ICU patients. There is no confusion. But between crystalloid, nowadays there is little confusion between RL and NS. You can see this is a randomized, all the randomized control trial. Now they are going in favor of the RL. They are telling that Ringer's lactate has some anti-inflammatory effects as compared to NS due to their action on the G protein coupled receptor 81, which is a cell surface lactate receptor. That's why nowadays all the guideline they are telling RL preferred over NS. But there's some conflicting conclusion. If you can see, this is the recent meta-analysis. In this, you can see here, they found that if you compare severity of pancreatitis, risk of ICU admission to mortality benefit, there is no statistically significant benefit of resuscitating with RL compared to NS. That means still now we have to go for further research to which type of fluid we should go for acute pancreatitis. Second aspect of the fluid is amount of fluid, that is whether we should go for aggressive resuscitation or restricted fluid resuscitation. What do you mean by early aggressive fluid resuscitation? That means we have to transfuse 1/3 of the body's 72 hours fluid requirement within the first 24 hours of the presentation. But nowadays, this is the randomized control trial. Nowadays, every trial they are going in favor of the non-aggressive resuscitation, because the latest evidence which is published in NEGM 2022, this is the waterfall trial. This is the most recent trial which favors restricted intravenous fluid administration decreases the risk of AKI, pulmonary edema, and the need of mechanical ventilation. Apart from that, aggressive fluid giving aggressive fluid, it can cause bowel edema and increases the risk of intra-abdominal hypertension. That's why this trial, they're supporting moderate resuscitation, that is up to 1.5 ml per kg per hour, and the bolus of maximum up to 10 ml per kg per hour only in the presence of the hypovolemia. Now, the thing is, so what are the challenges due to resuscitation we usually face in the intensive care unit? So how much fluid is sequestered? So, although it is well known that some patients with acute pancreatitis have an increased need of fluid therapy, but it is not clear who should get fluid aggressively. That means in all types of sick patients, it is not clear which patient should give more fluid and which patient should give less fluid. Apart from that, does one size fit for all? Why? All the guidelines presume that patients should report within 24 hours of the onset of the pancreatitis. Since this is not the case, generally, especially referral center, there is a need to take this factor into account, as the longer the delay in hospitalization, the more established the hemodynamic alterations become. That means in all patients, it is not fit to this patient. Depending on the presentation, we should assess how much fluid to give to the patient. Third one, patients with comorbidity conditions like renal failure patients, cardiac compromised patients, pulmonary disease patients need special attention during aggressive resuscitation during IV fluid. Now, coming to what is our target goal of resuscitation. Nowadays, in all the guidelines for the pancreatitis, we are targeting hematocrit, BUN. These two usually used. in some areas we use in lactate, though lactate has not much study in cases of the acute pancreatitis. That's why nowadays we should focus more on the dynamic parameter, especially like all types of like septic patients. We should go for a passive leg raising, stroke volume variation, pulse pressure variation, especially with the use of advanced echo or bedside ultrasound. So the challenge is to combine. So there is considerable heterogeneity in the study design among various studies, the rate and type of fluid studies, study population, outcome variables. There is positive evidence to recommend aggressive versus restrictive fluid, though the recent one is going for the restrictive one. The need of the hour is to incorporate a non-invasive method to assess the patient's hydration status, dynamic hemodynamic monitoring, to determine a patient-centric treatment strategy should be there to assess and resuscitate volume status in acute pancreatitis. Now, coming to another important aspect, the nutrition. So, there is two aspects, whether to start early or late and which route to start. First, we'll go which is preferred, whether you should go early or late. But nowadays, all the guidelines, they are going for early enteral nutrition therapy in acute pancreatitis. That is, we call this concept of gut rousing as opposed to gut resting. So, but the caveat is here, most studies were performed in mild acute pancreatitis. Only few studies in moderately severe and severe diseases in starting early enteral nutrition. In severe acute pancreatitis, almost most of the patients going to hemodynamic unstable with rising inotrope, high gastric residual volume, worsening intra-abdominal pressure, worsening metabolic acidosis. In that condition, starting enteral nutrition therapy may be challenging. This is a study done by Becker et al., which is a large randomized controlled trial, where they found early enteral feeding, that is within 24 hours of the admission. They found that that did not reduce the rate of infection and did not reduce the mortality as compared to the delayed enteral feeding. So that's why, though we are still using enteral feeding in severe acute pancreatitis, but there is still some challenges we face intensivist as in the day-to-day care practices. Then comes which route is preferred, whether you should go for NG or NJ. Though all the guidelines now are going for NJ feeding, so nasogastric feeding, because it is easy to insert, and because nasojejunal, you know that it should be inserted, it requires interventional radiology or endoscopic, thus it is expensive. Though NG is usually preferred, but evidences establishes safety, feasibility, tolerability for NG feeding as compared to NJ is there. Though NG feeding, there is a risk of aspiration, especially if the intra-abdominal pressure is high. Whether NG feeding affects disease mortality, its morbidity is debatable. That means, though we are starting NG feeding as compared to NJ feeding, the mortality benefit whether is there is not, we don't know. Now, coming to another aspect is the antibiotics. Though all the guidelines that nowadays they are telling that no role of prophylactic antibiotic, only if infection is there, whether it is pancreatic or extra pancreatic proven, we should start only antibiotic. But timing, the important thing is timing. So we should know at which time we should start antibiotic, because it is variable, unpredictable, and the incidence peaks of infections peaks during the 2 to 4 weeks of illness, where the gut translocations is the maximum, and reduced immunity will be the maximum, that cases. So the timing, we should know exact timing to start up the antibiotics. Apart from that, the marker, we should know what are the evidence of the marker to start antibiotics, especially what culture, pancreatic necrotic aspirate and drainage sample we are taking. Apart from this sample, sometimes we rely on the imaging where we found air in the collection, that is air we can find in the pancreatic collection, that is evidence that that patient is going to the pancreatic infection. But none of these provides absolute certainty in the diagnosis of the infection. Apart from that, whatever we rely is the procalcitonin, but the procalcitonin level elevated very early prior to development of the necrosis. That's why all these marker, 100% they cannot tell us whether we should start antibiotic early or not. So apart from that, we should distinguish the SARS versus sepsis. As you know that in pancreatitis, SARS is present at the time of admission. So differentiating between SARS and sepsis, it is extremely difficult, especially in the severe acute pancreatitis. So because this picture can be present with sterile pancreatic inflammation or pancreatitis with sepsis. So if you are not able to distinguish between SARS and sepsis, then to start antibiotic, it will be difficult. Now, coming with the choice of the antibiotic. So you can see this is the 5 types of common antibiotic which are commonly used in the intensive care unit. Aminoglycoside, you know that in standard intravenous dose fails to penetrate in the pancreas. Cephalosporin and piperacin, tazobactam, penicillin, this has intermediate penetration into pancreatic tissue. Carbapenem, though it has a very good tissue penetration, excellent anaerobic coverage, especially in the necrotic pancreatitis, but due to spread of the carbapenem resistant Klebsiella pneumoniae, the use should be optimized and should be used only in very critically ill patients. Quinolone, though it has good penetration and anaerobic coverage, but due to high rate of resistant worldwide, it is not a good choice. Metronidazole is a good tissue penetration and excellent anaerobic coverage, and it is not a broad spectrum antibiotic. We cannot start it alone. Now coming to the antifungal, though in critical ill patient with pancreatic fungal infection, differentiating between invasive fungal infection from the colitis is really difficult. That's why to start antifungal, it is really challenging in the intensive care unit. So what are the modalities available to diagnose fungal infection, like histological sample or samples we should take for the perioperative sample, cultures from the drain catheter, the blood culture, and the biomarker. So these biomarker and the culture is extremely costly. Usually in all patients who usually not do, it's challenging. So that's why they're telling that clinical judgment should be exercised when starting antifungal based on the likely diagnosis of the invasive fungal infection, whereas it should be started in all cases with a definite diagnosis, like if it is if the candidate score is high or if the blood culture is positive, we should start antifungal. So antifungal may be added considering clinical profile, risk factors for the pancreatic fungal infection, such as prolonged intensive care, high antibiotics, prolonged antibiotics, TPN, indwelling catheter, if this patient is going for surgery. In that cases, we should have a low threshold to start antifungal. Now, one more thing is anticoagulation. Though in the intensive care unit, it is a must for all patients as these patients are bedbound. So the use of anticoagulation in acute pancreatitis there is very less study in the literature, and challenging because this disease can give to 2 types of complications. One is splanchnic thrombosis, splenic vein thrombosis. Another thing is these patients can bleed, like retroperitoneal bleed. It's massive torrential bleed. With this patient can die also. So managing of these 2 opposing complications pose a unique challenge for a clinician, whether to start with chemical thromboprophylaxis or like mechanical prophylaxis. Especially for chemical prophylaxis, it is a challenge for the ICU specialist. Now, as you know that these pancreatitis patients present with severe abdominal pain. So we should have a protocol for how to start pain analgesia for acute pancreatitis. The step 1 is like paracetamol and the NSAID if the kidney is okay. And the step 2 is low potency opioid like tramadol. Then we go for high potency tramadol, fentanyl, buprenorphine. Then we go for stage 4, we can go for interventional treatment. But the thing is, interventional treatment like epidural, sometimes for epidural there will be challenge because this patient may have coagulopathy, this patient may develop catheter related hypotension, and the risk of epidural abscess. These are the risk of introducing epidural catheter, especially in a critically ill patient. Also putting epidural catheter if the patient is like edematous is really difficult in the intensive care unit. About the NSAID, the risk of AKI and peptic ulcer disease. Opioid, the downside in pancreatitis is it is a very good analgesic, especially in the pancreatitis, but it has the downside, it is caused ileus, which may increase the ileus already existing in a pancreatitis. We can increase the intra-abdominal pressure. Now, coming to the surgical part. So what is the ideal time of intervention in pancreatitis? Though in all the guidelines, they are telling that surgical intervention should not be done before 4 weeks onset of the disease, because by the 4 weeks, that all the liquefied matter, they will there have a like calcification, and there will be capsule. But it is not known how long surgery can postpone if the patients can tolerate. Second thing, will the longer delay result in more complications, increased rate of bowel fistula or intestinal obstruction? That means delaying pancreatitis, delaying surgery, whether it is has downside of on the patients, we don't know. This is a trial, pointer trial, which compared early versus delayed drainage in pancreatitis. They did not show the superiority of early drainage. Early drainage, they found that required a higher number of re-intervention compared to delayed strategy. That's why correct timing of interventions requires careful clinical judgment. A subset of patients with infective collections, sepsis, persistent or new organ failure may require early drainage. Now, coming which type of intervention, whether you should go for a percutaneous or endoscopy, that depends on multiple factors. That means the time since the onset of the disease, whether the collection is encapsulated or not, location of the collection, solid content of the collection, hemodynamic condition of the patient, and the available expertise. So, whether you go for percutaneous drainage or endoscopic drainage depends on whether, if it is a centrally located collector and well demarcated wall is there, we should prefer for the endoscopic. And in rest cases like early pancreatic collection, ill-defined wall, sicker patients, peripheral located collections, and less expertise, we should go for a percutaneous drainage. But the challenge in endoscopic is, it is possible when there is a visible bulge, which is found in only 40 to 50% cases in the patients. Otherwise, it's difficult where to go for the endoscopic drainage. So, apart from that, it is costly, especially endoscopic ultrasound, and it needs expertise. Whereas in cases of the percutaneous drainage, the most dreaded complication is the pancreatico-cutaneous fistula. Now, the surgical intervention, what is surgical intervention? Usually nowadays they are going for minimally invasive step-up approach. That means that surgery should be minimally invasive one rather than open surgery, and the step-up approach is initial drainage followed by debridement and necrosectomy if possible. So what are the indications of the surgery? Especially if the patient having abdominal compartment syndrome, acute ongoing bleeding where endovascular approach is unsuccessful, bowel ischemia, and bowel fistula extending into a peripancreatic collection. In that cases only you should go for a surgical intervention. Now, just one complications I have mentioned here, this is intra-abdominal hypertension. So why intra-abdominal hypertension is more common in pancreatitis? Because this is due to increased systemic permeability due to systemic inflammations, aggressive fluid resuscitation, and the vasoactive drugs leading to gut failure and worsening of the intra-abdominal pressure. Apart from that, excessive sedations can further worsen gut dysfunction with subsequent increased intra-abdominal pressure. So all these conditions lead to increased intra-abdominal pressure, especially in a case of severe acute pancreatitis. That's why to limit this, we should limit use ICU medications when side effects overcome beneficial is very, very crucial. That means if the patient is not requiring sedation, we should avoid. We should drain our luminal contents. We should not aggressively go for resuscitation. So to summarize, the management of acute pancreatitis in intensive care unit is still a work in progress. Even though there are several guidelines, there is a lack of consensus on certain issues. Choice and types of fluid resuscitation are still evolving. The nutrition aspect is settled with ample evidence for early nutrition, enteral nutrition. The judicious use of antibiotics is always debatable. The ideal analgesic is unknown because all has some downside is there. The intervention is trending towards endoscopy or percutaneous drainage rather than surgery. Thank you.
Thank you, Dr. Mohanty. This is really, really extensive and well-researched. I'll actually just do 2 questions so that we can close the loop here. There's one question in the chat box which asks about the use of steroids in pancreatitis.
Yeah, madam. Actually, I was searching for the role of steroid in pancreatitis. I'm not getting. Rather, I am going for all the immunomodulatory therapy. So all the guidelines, they are telling that like immunosin alpha and like our illuminastatin all has some immunomodulatory effect because it is a immunoinflammatory response is there, but none of the guidelines, they are telling that it has mortality benefit. So, but regarding steroid, I'm searching, there is no such guideline, the role of steroid in acute pancreatitis. Only immunosin alpha and illuminastatin, rather all the like inflammatory marker which can inhibit like cytokine, they have some actions without mortality benefit.
There's one question I would like to ask is about how often would you use albumin in this subset of patients?
Actually, like here in this type of cases, as per the like sepsis guideline, where still albumin we are using when the crystalloid load is much more. So that means when we are using aggressive fluid therapy, even after giving crystalloid therapy, if you are not able to maintain the like MAP before, even we are adding that like inotrope, sometimes we go for the albumin infusion, but usually we don't go. Usually, in my setup, usually we don't go for the albumin because in that cases, especially in the pancreatitis patients already presented with early features of acute lung injury, and though pleurally featured acute lung injury, still we are not favoring albumin in that cases because mostly this patient might go to early ARDS. In that cases, adding albumin already will it will cause more harm to the lungs.
And another very popular question a lot of people ask is that we see that by day 4, day 5, they are close to 10 liters positive. They're really swollen up. That's where, we also see AKI settling in. How soon would you like to maybe start CRRT to offload them if they're hemodynamically stable?
Okay, madam. Actually, thing is, if the patient is making urine and with the diuretics, if it is maintaining, it's okay. But if it is not maintaining, my lungs is already flooded and patient is oxygen requirement is going off, then I can go for a CRRT. I think I have to unload like only for volume removal. We can go for slide with some fluid, or if patient is hemodynamic unstable, is not maintaining anything, then you can go for a CRRT. But usually first try is if the patient is able to make urine with the diuretics, or first one is we have to restrict the fluid by the time. Then we have to, if the hemodynamically stability is there and the patient is able to make urine with the diuretic, then we'll go for the diuretic. Third thing is if this patient is hemodynamic unstable, is not tolerate the like SLAD or intermittent dialysis, for like scarf, I will go for only for fluid removal, will for a scarf. But if the patient is unstable, then we will go for a CRT. Ideally, if the by the day 5, if the patient is bloating already and my lungs is bloating and is not maintaining and intra blood pressure is high, already third spacing started, I think we should go for a CRT.
Okay, thank you, Dr. Mohanty. If you can let me share my slide, please.
Yeah, sure.
So now I will invite Dr. Vivek Dave. He heads the department at Narayana Multi-Speciality Hospital at Ahmedabad, and he'll be talking about mesenteric ischemia disorders where there is circulation insufficiency, which derives the oxygenation to one or maybe several abdominal organs, where one cannot meet the metabolic demands. It's rare. We need to identify these early. It could be because of an embolic phenomena or a thrombotic phenomena, or it could be just a non-inclusive issue. We need to have a very high index of suspicion. So I now invite Dr. Dave to please take the stage and to present the next topic on mesenteric ischemia.
So first of all, I'd like to thank Team ISCCM for inviting me over here in this webinar. And it's always a pleasure and honor to be a part of this esteemed faculty. So the topic is mesenteric ischemia. And you all are knowing that mesenteric ischemia also stands MI. Acute mesenteric ischemia is AMI. Just like acute myocardial infarction. Whenever there is heart attack, we call acute myocardial infarction. Similarly, when there is a bowel attack, we know we are calling as acute mesenteric ischemia. And it has been mentioned that is calamitous bowel state. So it is catastrophic, dangerous, and always challenging for the clinician. And you can see the picture in the first slide itself. It's quite life-threatening. Kindly change the slide, Chirag. Yeah. So now I have just depicted a case where a 51 years old male patient with a known case of hypertension, diabetes, and IHD presented with abdominal pain since last 3 days, associated with nausea, vomiting, mild epigastric pain, and on examination, patient having generalized abdominal discomfort with guarding rigidity. Rest of the systemic findings were not revealed anything significant. Vitals are heart rate 110, blood pressure 156/90, respiratory rate 28 per minute. Saturation is 94 to 95% on room air. And in the sonography, it's suggestive of dilated bowel loops with changes of fatty liver. So till these many lines and these many history suggestive of many differential diagnoses in your mind. Now, kindly just click, Chirag. There is some technical issue, so I have shared my slide to Chirag and at a back end. So now, in CECT abdomen pelvis, it's suggestive of mesenteric venous thrombosis with signs of small bowel ischemia. So the moment you see this line, you have that so many things in your mind, and it's quite alarming, right? Next slide, please. Go ahead. So acute mesenteric ischemia is a vascular emergency with overall mortality of 50 to 90%. Next, please. It leads to intestinal ischemia in approximately 20% of cases. And diagnosis of acute mesenteric ischemia is difficult due to lack of clinical and biological specificity, and imaging plays a very key role. And underlying cause should always be sought. So, by definition, acute mesenteric ischemia is a syndrome caused by inadequate blood flow through the mesenteric vessels, resulting in ischemia and eventual gangrene of the bowel wall. Although relatively rare, it is a potentially life-threatening condition. So, whenever you come across this kind of presentation, you have to have a mesenteric ischemia as one of the differential diagnoses in your mind. Next slide, please. So now this is the blood supply of colon. As you can see that mesenteric artery is commonly superior mesenteric and inferior mesenteric artery, and SMA is largely supplying the small and large bowel, and in IMA it's supplying the largely the large bowel alone. Next, please. So, very famous surgeon in 1930, Kokikins, one of the great surgeons from Royal College of Surgeons, he has quoted that occlusions of mesenteric vessels is apt to be regarded as one of those conditions of which the diagnosis is impossible, the prognosis is hopeless, and the treatment is almost useless. So, this quote itself suggests that whenever a mesenteric ischemia we are suspecting and it actually comes up, it's having extreme difficulties faced by the clinicians treating acute mesenteric ischemia. So symptoms are non-specific initially before evidence of peritonitis presence. So the diagnosis and treatment are often delayed until the disease is advanced. But fortunately, as the medicine advances, so many of the diagnostic modalities in form of MRI, Doppler flowmetry, and CT angiography have been made that allow earlier diagnosis and treatment. So the prognosis remains grave for patients whom the diagnosis is delayed until bowel infarction has already occurred. And unfortunately, many of the patients of mesenteric ischemia are presenting very late. So by the time all the necrosis, bowel gangrenes has set in. So the patients who receive the appropriate treatment early, so those are very fortunate, so that those patients tend to recover. Next, please. So as this slide has depicted that what happens to bowel during absolute ischemia. So you can see that initial 15 minutes, there is a structural changes into the intestinal villi. As the time progresses, mucosal sloughing, and still it's a reversible phase in first 3 hours. As the time progresses to 6 hours, that there is a transmural necrosis, gangrene, eventual perforation, and patient comes with changes of peritonitis. Next, please. So the clinical course and treatment of acute mesenteric ischemia, as I have mentioned earlier, that time is crucial. And as you can see that onset of symptoms, then first 4 hours, there is a conservative line of treatment, routine diagnosis, and then the irreversible phase that sets in as the time passes. And that can be depicted in the next slide. That you can see that the lethality of acute mesenteric ischemia rises exponentially from 10 to 100% within 24 hours. So that's why it is very paramount that it's supposed to be diagnosed on time for the betterment of the patient. Otherwise, as the time passes, the ischemia turns into necrosis and then gangrene, and patient presented very late, and then there will not be much of a thing that we can able to do. Next, please. So as I have mentioned with all the highlighted fonts, that acute mesenteric ischemia is a serious life-threatening surgical emergency. The most important message is to have a high index of suspicion based on the combination of history of abrupt onset of abdominal pain along with lactic acidosis and organ failure. The prompt imaging, CT angiography, should be done in order to establish the diagnosis is such a clinical scenario. And in the parallel with rapid resuscitation and after careful assessment of the CT angiography, the patient should be explored as early as possible to assess the bowel viability, re-establish the vascular flow, and resect the non-viable bowel. We'll go through one by one as far as the causes, pathophysiology, and the management part. In the operating room, the sole focus must be on the revascularization as a priority. And the classically open revascularization approaches have been used and described in combination with two things: damage control laparotomy, and the recent developments have come up with the endovascular techniques as well, as especially in the mesenteric vein and arterial thrombosis. Preliminary evidence suggests that the treatment of acute mesenteric ischemia is especially dedicated centers using a multidisciplinary approach that improves the outcome. Next slide. As you can see here, that in the contrast imaging with angiography, it's showing the green arrows. It shows there is a thrombosis of the superior mesenteric vein, partial thrombosis of the portal vein with the blue arrow, and in the ileal wall thickening with submucosal edema with the red arrows. Next, please. So these all are the features of CT scan when we are suspecting mesenteric ischemia. So these all are the changes that happen inside the abdomen. Like in case of SMA thrombosis, you can see on the first image, bowel wall thickening. Because of the ischemia, there is a translocation of the bacteria as well. There is a colitic kind of a changes, non-enhanced bowel wall, pneumatosis intestinalis, portal venous gas, and fluid collection. So these all are the CT scan changes in a case of mesenteric ischemia. Next. So now let's come to the types and etiology. So broadly, acute mesenteric ischemia is classified broadly in arterial and venous. So the AMI as arterial disease may be subdivided into non-occlusive mesenteric ischemia and occlusive mesenteric ischemia. And in occlusive mesenteric arterial ischemia, it's further divided into arterial acute mesenteric arterial embolism and acute mesenteric arterial thrombosis, right? And in venous, it's mesenteric venous thrombosis. So let's go one by one as far as the types of mesenteric ischemia are concerned. Next, please. So now acute mesenteric arterial embolism. So embolic AMI, it's like a bowel attack. And as it happened with the cardioembolic stroke and all these things, so the source of emboli from the cardiac, so there is a mural thrombus after myocardial infarction and the auricular thrombus associated with mitral stenosis. Other sources like emboli fragments of proximal aortic thrombus due to a ruptured atheromatous plaque, dislodged by arterial catheterization or surgery. So the most emboli lodge in the SMA because of this arterial anatomical placement of SMA just distal to the origin of middle colic artery, and embolization is less often associated with ischemic disease than thrombosis and has a better survival rate when optimally treated. But still, arterial embolism, for instance, usually occurs in healthy and unprepared vascular areas, so promptly leading to severe defect. So this is the overall summary of the embolism. Acute mesenteric arterial embolism. Next is acute mesenteric arterial thrombosis. So these all are the causes. Most common is, as we all are knowing, atherosclerotic vascular disease. Others are aortic aneurysm, aortic dissection, arthritis, any kind of a low cardiac output state, right? So unlike embolic events, which generally occur in arterial branches and result in limited bowel ischemia, thrombosis typically occurs at the vessel's origin, right? And it results into extensive bowel involvement. Next. Now the next is non-occlusive mesenteric ischemia. We are receiving those patients who are having a multi-organ involvement in a shock like a cardiogenic shock, septic shock. So these all are present with non-occlusive mesenteric ischemia. As it has been mentioned that hypertension from CHF, MI, sepsis, severe liver or renal disease, or any kind of a recent major cardiac or abdominal surgery and going into the shock. Other common etiology of this is very stiff doses of vasopressors, ergotamines, cocaines and all, right? So the prognosis of non-occlusive mesenteric ischemia is particularly very grim, and the lethality of 50 to 70% in case of vascular spasm of extensive intestinal segments. And many a times patient presented with refractory shock because of prolonged hypoperfusion state. Next. Now the next is mesenteric venous thrombosis. So more than 80% of patients with MVT are found to have predisposing conditions like hypercoagulability from any of these reasons, tumor causing venous compression or hypercoagulability, infection usually intra-abdominal like severe peritonitis, perforation and all these things, venous congestion from cirrhosis, venous trauma from accidents or surgeries, pancreatitis, decompression sickness. So these all are the predisposing factors which eventually lead to mesenteric venous thrombosis. Next. So now comes to pathogenesis of acute mesenteric ischemia. As you can see that these all are the risk factors, as I have mentioned earlier, that acute mesenteric arterial embolism like AF with recent MI, cardiac thrombi, mitral valve disease and all. With acute mesenteric arterial thrombosis, atherosclerotic diseases and all, with non-occlusive mesenteric ischemia, cardiac failure, low output state, multi-organ dysfunction. These all are the risk factors. And the clinical onset mesenteric arterial embolism is a sudden, strong abdominal pain with vomiting. In case of arterial thrombosis, progressive or sudden abdominal pain, vomiting, diarrhea, and all these things. With non-occlusive, progressive pain. And in the mesenteric venous thrombosis, non-specific GI symptoms, abdominal distension. These all are the particular clinical onset and presentation as far as the mesenteric ischemia is concerned. And the vascular involvement is concerned that acute mesenteric arterial embolism, there is a main arterial branches of SMA. In mesenteric arterial thrombosis, celiac trunk, SMA or IMA origins. And in the non-occlusive superior mesenteric vein or progression to portal vein. And in the venous thrombosis, stenosis of the mesenteric vessels. Next. Now comes to the differential diagnosis. As I have mentioned in the first slide that whenever the patient present with abdominal pain, with tachycardia and all these things, so there are so many differential diagnoses come in our mind. Like first is, as it has been mentioned here, that it's abdominal pathologies, like any kind of acute abdomen, like intestinal occlusion, perforation, inflammation of intra-abdominal organs, biliary colic, and others are vascular pathologies. urinary tract pathologies, traumatic, gynecological. So these all are the sets of differential diagnosis whenever patient comes with this kind of presentation. But always, as I have mentioned earlier as well, that mesenteric ischemia is a life-threatening situation, and whenever there is a disproportionate abdominal pain along with other important markers like lactate and all, early CT angiography is always very, very important. Next. Next slide, please. Chirag, kindly change the slide, please. Yeah. So now a clinical suspicion. So as it has been mentioned that patients with multiple comorbidities like hypertension, IHD, diabetes, atrial fibrillation, renal failure, and past history of atherosclerotic diseases. So these all are the very, very important thing in the history that you can suspect mesenteric ischemia along with the signs and symptoms. It has been mentioned in the other image like abdominal pain, classical. So it's 95% in case of mesenteric ischemia patient having this kind of symptoms like abdominal pain, nausea, vomiting, diarrhea and all. And the laboratory test suggestive of leukocytosis, elevated lactate with metabolic acidosis. So most symptoms and signs are non-specific, need to be excluded. So you have to put all these things together, right? Along with the history and clinical examination and the laboratory findings. Next. So now prognostic parameters as far as acute mesenteric ischemia is concerned. So these all are the points that you need to keep in your mind, and pathogenesis of the occlusion. So the etiology that you need to see, affected intestinal artery, location of the occlusion, whether it is central or peripheral, degree of ischemia, complete or reversible, extent of ischemia, and affected intestinal segment. So because of all these points, you can prognosticate as far as the acute mesenteric ischemia and the level of bowel involvement is there. Next. Now, as far as the approach is concerned, so one side there is a medical approach, immediate resuscitation, and other is a surgical exploration and surgical approach. So before surgery, bowel rest, fluid resuscitation, close hemodynamic monitoring, nasogastric decompression, indwelling urinary catheterization, parenteral antibiotics, and anticoagulation by heparin, right? So these all are the immediate resuscitative measure before surgery. And in surgical exploration, as I have mentioned, that assessment of bowel viability, determination of underlying cause, mesenteric revascularization, resection of necrotic bowel, and second look laparotomy, right? So I summarize in that way. We'll go one by one. Next slide, please. So now the management option as far as the medications part is concerned. So first is vasodilators in form of papaverine. So in the absence of peritoneal signs, so it is one of the drug of choice for acute mesenteric ischemia of arterial origin if angiography indicates good distal perfusion. And it's a local intraarterial papaverine infusion therapy in patient with non-occlusive mesenteric ischemia and significantly increases the survival rate. Next. And other medications like thrombolytic therapy, anticoagulations, antibiotics, and analgesics, right? So the thrombolytics, as we all are knowing, altiplase, retiplase, and tenecteplase. In anticoagulants, low molecular heparin, and in antibiotics, because early antibiotic is one of the recommendation in guideline because of bacterial translocation from the ischemic bowel segments caused by the disturbed mucosal barrier. Next. Now, initial resuscitation and stabilization part. So this is very crucial. First is the early establishment of the diagnosis of mesenteric ischemia. And once it's settled, once it's done, then we have to resuscitate as early as possible in a methodical way. There is every effort should be made to improve patient's cardiovascular status. So the oxygen should be provided to maintain saturation, early intubation in unstable patients, which will improve the oxygenation and allow more aggressive fluid resuscitation. If hypovolemia is considered likely, then IV fluid resuscitation is required with the normal saline, and the blood products are provided if required. Adequacy of resuscitation can be determined by means of urine output, bedside hemodynamic monitoring, nasogastric tube supposed to be inserted, and in arrhythmias or congestive heart failure or myocardial infarction should be treated, if at all, along with it. Avoid stiff doses of vasopressors because it also causes severe intense peripheral vasoconstriction. So it worsens the ischemia by intense vasoconstriction. Particular attention should be given to adequate fluid resuscitation with crystalloid solutions as well as blood derivatives to achieve a hemodynamic stabilization. And as it has been mentioned everywhere that to avoid volume overload, we have to have a moderate aggressive fluid resuscitation, just like in other shock scenarios. Next. Now, it is updated guidelines in World Society of Abdominal Surgeries, that is endovascular procedures in occlusion of SMA. So these all are the endovascular procedure, that aspiration embolectomy, SMA thrombolysis, antegrade stenting, and retrograde stenting. And what are the advantages and challenges? So in aspiration embolectomy, there is a lower mortality. Patients without peritonitis you need to attempt, and repeat procedures are likely. And in SMA thrombolysis, bleeding complications, laparotomy required in 40-50 patients without peritonitis, and it's contraindicated in recent surgeries, trauma, and cerebrovascular bleeding. In antegrade stenting, risk of dissection is always likely, and it's unfavorable arterial angulation, where antegrade stenting is difficult and the challenging. And the last is retrograde stenting, laparotomy necessary, avoiding bypass when necrotic bowel present, and success is around 95%. Next. So this is the depiction of the management protocol of a patient with a suspected mesenteric ischemia. So first, when the patient present with severe abdominal pain and suspected for acute mesenteric ischemia, so what we should do, that first is resuscitation, antibiotics, nasogastric suction, electrolyte abnormalities, and optimize the patient for the surgery. Along with that, risk factor assessment and laboratory evaluation like D-dimer, lactic acid, WBC is as mentioned. As early as possible, CT angiography, it's a gold standard to stamp the diagnosis. And then what type of mesenteric ischemia is there? So whether it is embolic, thrombosis, non-occlusive, what kind of? And then the multidisciplinary team assessment and approach is established, like to initiate anticoagulation, hemodynamically, if hemodynamically unstable with peritonitis, then to go ahead with the laparotomy as a damage control surgery, possible revascularization, and plan re-laparotomy. And if the hemodynamic stable with no peritonitis, then you can go ahead with the revascularization with the endovascular approach along with laparoscopy, and then you need to find the how much the bowel is involved and the viability of the bowel related decision supposed to be taken. Next. Now comes the WSES guideline for the acute mesenteric ischemia. So those who are the strong recommendation. So as I have mentioned again, that severe abdominal pain out of proportion to physical examination findings should be assumed to be acute mesenteric ischemia until proved otherwise. Plain X-ray is not recommended in evaluating patients for intestinal ischemia. So it's always a gold standard is CT angiography. Next. So there are no laboratory parameters that are sufficiently accurate to conclude our diagnosis, but the supportive diagnosis like elevated lactate, leukocytosis, D-dimer may assist. It's weak, but a moderate degree of recommendation. And as it has been highlighted over here that it should be emphasized that the presence of lactic acidosis in combination with abdominal pain when the patient may not otherwise appear clinically ill should lead to consideration of early CT angio to establish the diagnosis of mesenteric ischemia as early as possible. Next. Computed tomography angiography should be performed without delay in any patient with suspicion of mesenteric ischemia. And delay in diagnosis is the dominant factor that accounts for high mortality rate of 30 to 70%, despite increased knowledge of this entity. And every 6-hour delay in diagnosis can double the mortality. And 6 radiological findings, again, it's summarized in recommendation that bowel loop dilatation, pneumatosis intestinalis, SMV thrombosis, free intraperitoneal fluid, portal vein thrombosis, and splenic vein thrombosis. So 6 radiological findings supposed to be considered. And it has been mentioned earlier as well in the form of CT images. Next. And when the diagnosis of mesenteric ischemia is made, fluid resuscitation should commence immediately to enhance visceral perfusion. Electrolyte abnormality should be corrected and nasogastric decompression initiated. So one of the strong recommendation, again, the broad spectrum antibiotics as early as possible, because there is a possibility of translocation of gut bacteria. So it has to be immediately administered. And prompt laparoscopy, laparotomy should be done for patients with an overt peritonitis. And the goal supposed to be re-establishment of the blood supply to the ischemic bowel, resection of all non-viable regions, and preservation of all viable bowel. Endovascular revascularization procedure are the primary option in cases of arterial occlusion when sufficient expertise is available, because there are a lot of challenges as we have mentioned and discussed earlier. Damage control surgery with temporary abdominal closure is an important adjunct for patients who require intestinal resection, and which allow reassessment of bowel viability and in a situation of severe abdominal sepsis. One more recommendation is mesenteric venous thrombosis can often be successfully treated with a continuous infusion of catheter-directed thrombolysis. The algorithm with post-operative CDT via SMA is associated with more favorable clinical outcome compared with the systemic anticoagulation. When non-occlusive mesenteric ischemia is suspected, the focus is to correct the underlying cause and improve mesenteric perfusion. Infected bowel should be resected promptly. In case of post-operative intensive care of mesenteric ischemia patient is directed toward the improved intestinal perfusion and prevention of multiple organ failure, because the post-operative ICU care is also very, very challenging and essential to safeguard the patient as far as the prevention of the multi-organ failure is concerned. Treatment of mesenteric ischemia is optimal in a dedicated center using a focused care bundle and multidisciplinary team. And the last is patients undergoing revascularization should have surveillance imaging and long-term anticoagulation. And these all are the poor prognostic indicators when there is an advanced age and presence of other comorbidities like severe cardiac, pulmonary, renal diseases. So these all are the having a poor prognostic indicators as far as the long-term patient survival is concerned. Thanks a lot. So as it has been mentioned that nothing is impossible, because the word itself says I am possible. So whenever we have a catastrophic challenging condition like mesenteric ischemia, so these all are the take-home messages that it has to be diagnosed as early as possible to safeguard the patient. Early CT angio, whenever you have all these symptoms like abdominal pain, and if you found elevated lactate with disproportionate pain, do early CT angio, stamp the diagnosis of mesenteric ischemia as early as possible, and treat it accordingly to safeguard patients. Thanks a lot.
Thank you, Dr. Vivek, for this extensive talk. Brilliantly done. Common question that a lot of people are asking is, what is the vasopressor of choice for when someone diagnoses mesenteric ischemia?
See, as far as mesenteric ischemia etiology is concerned, as I have mentioned that there are a variety of arterial and venous related occlusion. So as far as possible, we should avoid it. But many a times in case of non-occlusive mesenteric ischemia, if patient presented with shock, we don't have any other option to and to start vasopressors. So always the choice of vasopressor is always been noradrenaline. Intense vasoconstrictor like vasopressins and all are supposed to be avoided. And as far as the guidelines and recommendation has been concerned, as far as WSES, that early good initial resuscitation is always paramount.
So paucity of time, thank you so much. We will move on to the panel discussion. If I may share my slide. We go on to the panel discussion on acute liver failure, diagnosis, management, and recent advances. Dr. Govil would be our mentor. Our panelists would be Dr. Vaishali Salau. She heads the critical care unit at Fortis Mulund. We have Dr. Sulin Karan. He is the chairman and the head of the department at Manipal Hospital, Bangalore. We have Dr. Ravindra Gawat. He is alumni from TMH Mumbai and the director of critical care at Jupiter Hospital, Thane. And then we have Purva Kumar Bora. He is the head of the Department of Critical Care Medicine at Narayana Super Speciality Hospital, Guwahati. We have a case study of a 35-year-old female patient. She's a follow-up case of pulmonary COX on ATT for 1 month, presents with reduced appetite of 7 days, yellow discoloration of eyes and urine 5 days, altered sensorium for 2 days. She's disoriented, lethargic, with a respiratory rate of 26, a blood pressure of 90 by 50 millimeters of mercury, and a heart rate of 113 per minute. Labs say that she has an HB of 8.1, ELC of 9.1, and platelet of 1.4. Her sugars are 76, potassium and sodium so far is okay. Urea creatinine is fine. SGOT is 118, SGPT is 211, bilirubin is 3.1, and INR is 1.71. Dr. Salim, what is the diagnosis? What do you call this ALF, and what is the criteria for ALF?
Thank you, Dr. Lalita. Like any other patient, I think it's important to think of certain differentials when we get a presentation of this nature. Young man, there is a history of ATT presenting with altered sensorium of 2 days associated with jaundice and reduced sort of appetite, with the labs indicative of a transaminitis and an abnormal bilirubin and elevated INR. So the differentials that would go through would be the topical illnesses, different kinds of hepatitis, look for the etiology of hepatitis, and such other things. Now, coming to the first question, the diagnosis, this would fit into the diagnosis of liver failure. Why I say so? Because there is encephalopathy on the onset of hepatic dysfunction or abnormal liver function, which is characterized by an elevated bilirubin and an INR of more than 1.5. And when the duration of encephalopathy after the onset of jaundice or INR elevation is within 4 weeks, it would categorize as acute liver failure in most of the diagnosis or most of the systems of diagnosis or most of the systems, the criteria that we would use. Of course, within a week, which is in this case would categorize as hyperacute. But in the Indian classification, we do not look at hyperacute as a thing. So we would say that this is acute liver failure with most likely secondary to the ATT, drug-induced. But of course, we'll have to look for all the other possible markers because generally drug-induced is a diagnosis made based on exclusion as well.
Thank you, Dr. Sunil. We move to Dr. Ravindra. How does one classify liver failure?
So there are various systems depending on what is the duration of onset of encephalopathy from the onset of jaundice. And the most commonly used is the Grady's one, which divides into acute, hyperacute, acute, or subacute. And when the duration is less than 7 days or a week, it is hyperacute. Then from a week to around 4 weeks, it's acute and then subacute. This is the most commonly one used. And then there are other classifications as well, like the Bernay one and the Japanese classification. The Japanese classification actually says late onset hepatic failure is when after 8 weeks. So what is important to know is about this classification is the clinical significance of it. Like as the duration increases, the duration of jaundice to encephalopathy increases, the prognosis is worse. In subacute failure, the prognosis is worse. In fact, in hyperacute, it is best probably amongst all. Then the coagulopathy also decreases over a period of time, the appearance of and the establishment of coagulopathy. The jaundice though increases as it progresses from hyperacute to subacute or chronic. And also the in ICP, the cerebral edema, actually you would see it more in the hyperacute as compared to subacute where the cerebral edema would be less. The other thing is that you can also look at the etiologies. Like in hyperacute, the most common would be in Western countries, probably drugs like paracetamol, the acetaminophen, and in our country, probably hepatitis. The infective hepatitis like hepatitis E and A, and in the acute phase, the next phase would be, or acute from 1 week to 4 weeks, would be hepatitis B. And in the subacute classification or subacute category would be most of like autoimmune or acute on chronic liver failures or other drugs than acetaminophen. So that is how we need to look at the classification.
So, Dr. Purva, how would you like to investigate a patient further? So, in other words, if you're looking for the causes of ALF, what would you like to investigate?
Good evening, all. Good evening, man. The patient, 35 years old lady, with a history of tuberculosis on anti-tubercular drug, presented with all this, altered sensorium, jaundice. The first diagnosis will come to our mind is, ATT induced, it's a drug toxicity induced acute liver failure. So most commonly, isoniazid. So already we have seen the, bilirubin is high. So jaundice is there and yellow discoloration, altered sensorium, that is encephalopathy is present. So by definition, we need to see the coagulopathy. So we need prothrombin time and INR to certain the diagnosis. Now, if you want to assess what is the severity of the disease, so for assessing the severity of disease, you need PTNR level, that is okay, and full coagulation screen, and including fibrinogen, because this is required for severity, like factor 5. Less factor 5 is actually is a very bad prognostic marker. You can see important in liver function tests, LDH, and assessment of renal function. You can see the urine output hourly. And here, one important point is low urea is a marker of very severe liver dysfunction. So that is again can give you a clue about the severity. And ABG and lactate, very important. And
I would like to ask one thing here. So we know that we need to do arterial ammonia, but not everybody has a lab where they can do a stat ammonia. It goes somewhere outside. How reliable would you look at an ammonia which is coming, a couple of hours down the line from a lab outside?
it's difficult because the time. If after taking the sample, if you are taking more time for actually analyzing the sample, it actually give you falsely low ammonia level. So ideal is to do in a hospital setup itself, but if the hospital is not having the facility, it has to be transferred. It should be transferred, in a ice box, maintaining the temperature. But ideal is to do in a hospital setup. And yes, ma'am.
Sorry. So what are the other common causes of ALF that we know in our Indian setup?
So in Indian setup, you see, madam, first thing is the hepatitis. Hepatitis is very common in our area. So this hepatitis panel should be investigated, like HBsAg, anti-HBC, IgM, HB, V DNA, anti-HA-VIGM, then even anti-HE-VIGM, anti-HSV. There are lots of virus can cause also, like, varicella zoster in some selected cases, Epstein-Barr virus, even parvovirus. So all those things you can see, but in an individualized manner, it's not blanket to do all those things. But yes, hepatitis is the most common cause of acute liver failure in our part of the world. And second most is, ATT induced, anti-tubercular medicine induced. So that is very important. Again, toxicology screen, looking paracetamol serum level, because paracetamol is also one of the important cause, but not in our area. It is very common in developed countries. But yes, if there is history, then if you have a strong, suspicion, sometimes there is a history of, physical harm, suicidal ingestion of large dose of paracetamol. We used to find this type of patient. So paracetamol serum level is important. Then autoimmune markers in selected patient, you can do like ANA, anti-soluble liver antigen, ANCA, and anti-smooth muscle antibody, then globulin profile, HLA typing. These things can be done in an individualized manner. And sometimes the complication, to check the complication, you can see the lipase level, amylase level. Now, if you see the etiology, there are lots of causes. Viral hepatitis, drug-induced hepatitis, hypoxia-induced liver injury, acute Budd-Chiari syndrome, veno-occlusive disease, Wilson disease, mushroom ingestion, sepsis, autoimmune hepatitis, acute fatty liver of pregnancy. This is a very, very important, because etiology changed the management. Even the HELP syndrome, heat stroke, malignant infiltration. So this whole list we need to go through. And drug and toxin, if you see, we have lots of drug that can cause, acute liver failure, like acetaminophen, alcohol, antidepressant like amitriptyline, nortriptyline. There are lots of drugs, oral hypoglycemic, anti-epileptic like phenytoin, valproate, an antibiotic like tetracycline, amoxicillin, cipro, doxycycline, erythromycin, isoniazid. This whole like anesthetic agent, halothane can again precipitate acute liver failure. But nowadays, use of halothane is very, very less. Statins, even immunosuppressant like cyclophosphamide, methotrexate, salicylate, gold, disulfiram, propyl uracil. So there are lots of toxin you can see. Even dose-dependent toxin. These are lots of bacillus cereus toxins, cyanobacteria toxin, organic solvent like carbon tetrachloride, yellow phosphorus, even the mushroom toxin, and there are lots of illicit drug abuse in a dose-dependent manner like ecstasy, cocaine. Now, lots of herbal supplements are there, which can, precipitate acute liver failure like ginseng. Lots of herbal product. So you need to be very careful in taking history. You need to be very careful. You have to, see, correlate things, and you need to be very careful and see patient in a very individualized manner.
Thank you, sir. So I think it's very important to take the history.
Yes.
And the last few conferences, yellow phosphorus has been a part of our discussion. And herbal supplement, or what we call as DILI, has also come up in a big way in causing acute liver failure. I request Dr. Vaishali Salal to take the next question as to how one can differentiate what is causing this acute liver failure. You're mute, Dr. Vaishali.
Sorry for that. So I think partly this question has already been answered by the previous panelist. So I'll be very brief in the interest of time. So basically, I think the history is the most important in Indian scenario. There is a fever and jaundice and altered sensorium. First, rule out the non-hepatotropic viruses, which is dengue right now, which remains on the top of our list. Dengue, malaria, followed by hepatotropic viruses, especially if the enzymes are in thousands. Then frequency-wise, if you go look at the DILI, history is extremely important for any hepatotoxic drugs, especially alternative medicines which the patient may be taking, or even allopathic medications for some other indications. Then Wilson's also, one should be carefully looking at the presence of hemolysis, low alkaline phosphatase. These are clues towards Wilson's. Ask for a KF ring assessment. And of course, the ceruloplasmin and the 24 hours hopper will help nail the diagnosis. Autoimmune, you need to send the markers, and sometimes you also have to do a biopsy to prove that it is autoimmune. But Chiari, we need the CT imaging or a Doppler at least to look at the flow in the hepatic veins and if there is a thrombus there. The other important etiology in the ICU to remember is ischemic hepatitis. We come across this quite frequently, even in general critical care. And again, the examination, the background, there will be some episode of hypotension or there will be an acute myocardial event in the last 24 to 48 hours. And the enzyme doubling time will be every 12 hours, which classically, with a low bilirubin, which classically tells you it's ischemic hepatitis. When you do the CT, you will come to know whether there is an infiltrative illness, whether there are infiltrates in the liver. And last but not the least, the HLH also remains an important diagnosis to rule out because these are patients whom you should not transplant. So doing a serum ferritin, triglycerides, and using all the criteria to rule out HLH is also important.
So Dr. Ravinder, how does it vary in different countries? Do we see the same thing as we see in the Western world?
So if you look at the data from the Western world, the drugs are more common, the most common being acetaminophen. And in the developed countries like India, it is the hepatitis which is more common. And if you can see the Bangladesh, it is around 70% causes hepatitis C. So if moving from Western world to Eastern side, the hepatitis becomes common, while in Western it is the drugs which are common.
So moving on with our case study, when one like to do an ICU admission, so we come to a diagnosis that yes, it's the drug, we have the ATT has caused the ALF. So let's look at how one would like to treat it. What is there a role of NAC? Does LAC play a role in non-PCM poisoning ALF? What is the role of prophylactic antibiotics? What is the role of steroids? What are the anticipated complications? So coming to Dr. Sunil, so what are the do's and don'ts in a peripheral hospital? So someone comes with an ALF in a peripheral hospital. What is your advice? What should they do? And how soon should they get to a peripheral center? And when should they be referred to the ICU?
So I think as a rule, all patients who have been diagnosed to be having acute liver failure ideally need to be monitored in either a ICU or at least in a monitored setup like an high dependency. I think development of complications is definitely an indication, specifically when we talk about development of encephalopathy. I think there is no doubt these patients need to be monitored, or if they need any form of organ support. Now, what is important in managing these patients in the ICU when you talk about do's is good intensive care unit, good intensive care management and a good amount of supportive management. That's the key to having managing these patients with acute liver failure, and when to refer them to the higher center where there is facility for transplant or any other form of liver support therapies, as we would call. Some of the highlights or some of the important differentiating aspects of managing these patients compared to a general ICU patient is strict asepsis, ensuring that they are sort of constantly monitored with all the aseptic precautions, look for signs of early infection, look for signs of early alteration in sensorium. It could be as mild as a grade 2 encephalopathy, because these are very important to make sure, because once encephalopathy sets in, it has a bearing on prognosis, it has a bearing on future management as well, or in terms of how we are going to manage these patients. Added to that, management of the complications is extremely important. If the patient is slipping into encephalopathy or showing signs of raised ICP, or is already in encephalopathy, monitoring for signs of ICP, such as looking at the flaps, looking at constant monitoring of the GCS, and non-invasive methods such as optic nerve sheath, and deciding on when to take the airway and early airway protection. I think this is the key as well when we talk about monitoring the encephalopathy or the sensorium part, like in any other patient who has an altered sensorium. Another take-home point is to remember that a lot of these patients, or in many of these patients, encephalopathy can be precipitated by various factors. One I have already mentioned, sepsis, prevent that, and managing of various electrolyte abnormalities is extremely important. It is also imperative to understand that de novo correction of coagulopathy is not recommended. Because coagulopathy is a very important part in how we are actually monitoring these patients. It's one of the indications to determine when a transplant is needed, when intervention such as plasmapheresis is needed. So there is no role for a correction of coagulopathy unless there is any active bleeding happening. So I think that is a very important part, particularly in centers which are not tuned to managing the routine managing ALF. I think they should be aware that coagulopathy is a very, very important marker. It's also important here to understand that these patients don't bleed easily, though they have abnormal coagulation profile, because often it is in these patients, it's often a rebalancing that happens, and therefore no necessity to correct coagulation in these people actively unless there is active bleeding happening. And very important, as I told, referring these patients at the right time to a higher center if you feel that they need liver support therapies, or for that matter, even transplant. If a patient develops encephalopathy, the most often secondary event of that, or secondary complication of that, is that they actually develop cerebral edema. So they may need early airway protection, neuroprotective measures like how we do in most neurocritical care setups, and essentially monitoring of the ICP, preferably nowadays through non-invasive modalities like pupillometry or optic nerve sheath, which is a very easy method of doing it.
So just
Dr. Gauri, I think we should close down the session now. It's 8:35 already.
Yes, sir,
So
it's
maybe
really
only
pulled
one
out.
question and then we can close it. We
Okay,
can
sir.
discuss later. Yeah.
Yeah, so just a question to Dr. Vaishali. So what is the role of NAC in non-acetaminophen acute liver failure? You're on silent.
So the first trial published by William Lee in 2009 was the first evidence that it actually helps even in non-acetaminophen acute liver failure. Since then, there have been multiple prospective studies and at least 3 meta-analysis. And each of these meta-analyses have included anywhere between 400 to 1,000 patients. And they have shown clearly there is an advantage of NAC in non-acetaminophen acute liver failure. What is the advantage? Advantage is the non-transplant survival is better. It actually works better if the encephalopathy is grade 1 or grade 2. Overall survival doesn't get affected, but non-transplant survival is better, and especially in cases of DILI, it has a specific role. It should be given in the same dose that we give in the paracetamol poisoning, that is 150 followed by 50 followed by 100 over 16 hours. Preferably IV. Mind you, if the patient is encephalopathic, oral, vomiting, aspiration remains a huge risk, so preferably IV. And we never land up giving oral at all. So yes, it is strongly indicated in non-acetaminophen acute liver failures also.
Just a quick question on antibiotics and steroids from Dr. Sunil.
So antibiotics, there is no role for prophylactic antibiotics, certainly. But in clinical practice, I think it is easier said than done, because we know that sepsis infections are one of the most common cause of precipitation of encephalopathy or such other decompensation or worsening of the ALF. So if at all there is suspicion and there is a need for antibiotics, particularly in the context of somebody developing shock or progressive worsening liver failure, then it is appropriate to start with the antibiotics based on what is best considered as the flora and fauna of the area from where the patient is, or in the hospital where the patient is. And it also depends on the duration of hospitalization. So early on, I would say BLIs, and beyond that, probably higher antibiotics. But proven infections, of course, we treat as per the sensitivity. Role of steroids in ALF, I think, is actually dwindling now. Its role is largely restricted to management of shock, low-dose steroids for shock, or septic shock, or where there is evidence of adrenal insufficiency. There could be a role for management for steroids in autoimmune kind of hepatitis, or associated autoimmune phenomena like autoimmune hemolysis or such a thing. Otherwise, it is largely indications which may not be directly related to ALF.
Okay. Dr. Vaishali could when I sent her the slide, she said that she doesn't use lactulose anymore. So it is still the first line of pharmacological treatment for hepatic encephalopathy.
Not in
No,
ALF.
not at all. Actually, if you see all the guidelines, whether it's the EASL guidelines, ASLD guidelines, or even the INASL guidelines, very clear, lactulose really doesn't have a role in acute encephalopathy of an acute liver failure. There is no evidence, first. And second, what has been found is that when you give load buckets of lactulose, it causes gaseous distension. And if this patient has to be taken onto the transplant table, the bowel is distended and it comes in the way of the transplant field. So from the evidence, guidelines, as well as the mechanistic complications it puts on table, lactulose really is not indicated in acute liver failure encephalopathy.
Yeah, on the table as well as even in the ICU, because it worsens respiratory embarrassment in many situations. So there is certainly no evidence for it in ALF.
Okay, we'll just quickly close this. Any contraindication to the transplant? Where would you say the transplant should not be done?
So I don't know who this question is for, but
Dr. Vaishali can take it, or anyone can take it.
Pick it up. Sorry if this was meant for the other panelists, but yes, the single most contraindication in an acute liver failure setting would be if the patient's neurological recovery is not possible. That means if you are sure that the patient is brain dead. Either pupils are fixed dilated, mind you, that's not the only criteria. You need to demonstrate by other techniques. So we monitor TCV. You look at the diastolic velocities, look at reversal of diastolic flow, and if required, even do a CT angio to prove that, yes, the cerebral edema has progressed so much that the patient is not going to wake up after transplant and neurologically not possible to salvage. The other contraindication would be very high inotropes, but that's a relative contrast. This is the only absolute one. And of course, if there are any concomitant conditions, but usually acute liver failure occurs in young, healthy individuals. But yes, any other concomitant condition which precludes, but that's the only absolute contraindication. The others are relative, like maybe ARDS, very high requirement of inotropes. This could be, but these are relative contraindications.
I think it's important to differentiate whether the other complications are a part of the acute liver failure, because if that differentiation is there, then as Dr. Vaishali said, they could still be considered for a transplant.
They should be. Even if you have some amount of aspiration pneumonia, as long as, because they are young, healthy individuals, you always have a VV ECMO in your hand in case the ARDS worsens. It should be, but each is case-to-case basis, and it's these are not absolute, except neurological brain death. The others are all relative contraindications.
Okay. I apologize to all the panelists. We were really short of time today. I would just request Dr. Deepak to just give a few words on some ongoing clinical trials in ALF, and just give us a brief outline as to what could be a management protocol in an ALF patient in his ICU.
Dr. Gauri, you have already shown the ongoing clinical studies. I think we are getting too late, so I'll take this opportunity just to close the session. Rest of the part we can discuss some other day at some other time.
Definitely, sir.
Yeah,
we're really over time
40
today.
minutes over, so we should close this session. And because the management protocol will be a long, like at least 5-10 minutes, so I don't want to go into this detail.
Right, sir.
I'm really sorry.
Okay, sir. So if you could please close the session, sir.
Yeah, so on the behalf of entire panelists and all the faculty, I would like to thank all the delegates who have joined today and stayed with us for a long time. And I hope this would have added in value for their knowledge and their clinical practice. Side by side, I would like to thank all the panelists and the speakers and Dr. Arif, Dr. Gauri, Dr. Vaishali and others. And thank you very much. Have a good night and see you soon again. Thank you very much.
Thanks a lot.
Thank you.
Thank
Thank
you.
you. Good night.